Ramesh here, and we have a great panel here. Okay.
Yeah, absolutely. We looked forward for this evening, and in fact, there are two challenging cases. One, Praveen was just showing, and this is also equally challenging because while the time we were waiting, so we just did few steps. So let me introduce this case. First, this is Dr. Rajneesh Kapoor and Dr. Himanshu Dabral. Dr. Sushil is here. Dr. Shyam and full team is here, and Dr. Karan was also here. And then there are guys with the OCT and imaging also. So let's introduce our case. Can we have the slide, Sushil? Okay. Okay. So this is a patient who came to us yesterday, 55-year-old male patient, had episode of chest pain few days back, and there were ECG changes and troponins were mildly elevated. There is no other morbidity, but yes, the patient is quite obese. He's almost slightly more than 100 kgs, and this was acute coronary syndrome. Although echo was fine, echo showed normal LV function, normal RV function, valves were okay. Uh, and this is the angiogram. He hails from some city near to Delhi, so he got his angio done there. So this is the angio which we have done today, but we have seen that angio yesterday, and this is the angiogram. This is RA caudal view. Look at this. LED is very densely calcified, and I'll show you a AP cranial view. Next view.
Are they seeing it?
Are we?
We don't see the angio. Can you? Can we
Okay.
see the angio?
Yeah, please. Is it
Now we
visible?
have the
Now we
angio.
can.
Okay, please come the RA caudal shot, previous shot. Okay. Okay, so this is the first shot, and densely calcified LED and diffuse disease in LED, long segment, and then there is a high obtuse marginal coming from circumflex, which is also osteally diseased, which is also tight. So acute coronary syndrome, dense long segment LED calcified lesion, and a tight lesion at obtuse marginal. AP cranial, next shot. Okay. No, sure. Okay, this is the AP cranial. Look, so LED is a long segment diffuse disease and quite densely calcified. So while the time as I mentioned, we were waiting, I'll also like to show you a caudal view. Please come the previous view. Okay. So just to show you that there is how's the ostium of LED. So looks like there is some space we can actually do the stenting from ostium, LED ostium onwards. Next. So just to give you a further detailing of this case, we did OCT of the LED. We wired with a normal workhorse wire, all star. Next. Next. Okay. So now look at this. There is a very tight lesion around a diagonal, and there is very tight lesion ahead also. We had a slight difficulty in wiring across that point of the diagonal tight lesion, I mean around the diagonal. And after this, we attempted OCT without any predilatations. We thought if it goes, we'll have a clear picture without disturbing the LED, but we could only take the OCT around that septal. So it's a heavily calcified vessel. Next.
This was the
So
farthest.
this is the OCT, and we could reach this point only. It was not going beyond that point, and the reason is very clear. That distal marker of the OCT is the point of the maximum tightest lesion. So it was not crossing that point. So we did the OCT of that area from septal LED backwards. Please show that OCT. Just to give you clarification of the extent of calcification and whether the proximal LED is involved and ostium is involved. Can we have the OCT image? Can you see the OCT image?
Yeah, we can see it on a small screen.
Okay, make it bigger.
No, it's okay.
Yeah. So look at it's almost a 300-degree calcification, and quite thickness of calcium is also big. So we are coming distally, proximal, from distal to proximal. Come to the ostium. No, don't move. Come back. Show the ostium of LAD.
Ostium already.
Come back. Okay, so this is the ostium. There is a circumflex, and then left main. Okay. So this is how we are placed here. We know there is one tight lesion which we still have to conquer that point. So this is the case. I think we can have your inputs and then tell we further advanced with few steps, and then we tell how we have actually done the next steps. Dr. Ramesh?
Yeah, let's ask, go ahead, from our panelists. And,
Dr. Kapoor, Goran speaking.
Hi, Goran.
Thank you for
Hi.
selecting. Nice to see you again,
Yeah.
and we look forward to the case. So in uncrossable lesion with really very severe calcified throughout the LAD, but also I'm afraid inside the left main, I think in my view, this is a case to prepare lesion with rota, post-dilate, and then stent all the way into the left main. So maybe, of course, we can postpone that decision regarding the proximal landing zone, but before, I think we should, this is uncrossable lesion at the level of bifurcation with rota, risk of occluding diagonal is relatively low. So my strategy would be rota, post-dilatation, repeat OCT, and then stenting.
I agree with that. So, yeah.
Manish?
Yeah, no, I totally agree with Goran here. This is a very heavily calcified mid-LAD. Orbital is a choice. I'd love to see what they did with orbital, but my choice here would be front-cutting rotational atherectomy with a 1.5 burr.
Okay, we have one, before we go on to the panelists, Dr. Azam.
Okay. Dr. Rajneesh, thank you very much. Oran, I want to know from your side actually, it is uncrossable lesion. Should I go for straightforward 1.25 or 1.5 balloon for a trial? If it goes down and dilated, then I can take change decision, or if it is not crossable, then instead I go for rotablation. If 1.5 balloon, I can try. If it is cross, it's okay. If it is not cross, then straight away go for the rotablation.
Yeah, straight to rotablation because you saw almost the whole vessel is full of calcium. So that calcium needs modification in order to be able to expand stent. Balloon dilatation will not help in that way.
So I agreed with that. I think I probably would choose either or. I would say atherectomy rather than just say one device versus the other, because both the devices with a rotational or orbital atherectomy are good enough to ablate in this type of situation. And
Yeah.
Bashir,
What is the left ventricular function in this patient? Because the length of the ablation that you will have to do is very long. So the
Yes.
chances that you're going to have a non-reflow, it is important. So what is the left ventricular function to see whether I would have considered additional support?
So LV function is normal.
Okay.
Yes,
Yeah.
so,
yes, sir.
but again, I would want to know the LVDP since we're going to be doing rotational atherectomy, just to kind of know your baseline in terms of starting. Again, your runs here would be slow and meticulous, give the patient a chance to breathe. I think those are very important elements of this. The other comment about ballooning this is that in many cases, before we had atherectomy and you balloon these lesions, you'd get a significant dissection. And so by doing atherectomy prior to ballooning, you can hopefully minimize that potential.
Yeah, with that much calcification, I will definitely go up front with atherectomy before doing anything.
Thank you.
Right, right.
So I think we have an agreement on the panel that rotational atherectomy directly.
Okay,
with
1 minute.
1.5 device.
Don, what do you think?
All right, so casting my brain back to fellowship, I would definitely go with atherectomy first. So now from my underserved country perspective, we have none of these devices available. So if I do a cath like this and I see all of that calcium, I'm probably stopping at this point and referring for surgery. Because, you know, I could see that it's very, very heavily calcified. We do not have the devices available to modify that, and it can cause harm rather than any benefit.
I think it's a very important point. Like back home in Pakistan, also there are very few labs that have rota, and they end up trying this and then failing it. It's better to just stop there, send somewhere where there is a atherectomy device, or send for surgery instead of trying this.
Balloons.
Absolutely. So
Okay, so I think that it's a good discussion with the panel that it's a very densely calcified LED and we require some calcium modification. Atherectomy device is the choice, and so I tell you what we did. Okay, so this is then you know we have to change it to a Viper wire. So we were planning a orbital. We were prepared for orbital. We didn't expect as a non-crossable lesion here. We thought we'll pass our Viper wire easily and do the orbital to the whole segment. And then obviously after the modification, we should be better off with the vessel and stent it. Okay, so then one of the such type cases where the lesion is very, very tight, the having the two wires down is difficult, you know. So we thought let's first try the balloon if we can slightly make a more passage at that maximum tight lesion. So we tried balloon, this is 1.5, didn't go. We tried 1O balloon, didn't go. There are a few shots missing. Then we tried a 0.7 LVO balloon, and again it showed a lot of resistance. We could actually manage 0.7 LVO balloon just across that point, dilate little bit to have a passage for a Viper wire, and then only that point, and this is a passage of a Viper wire. We can get the Viper wire down next, and this is a Viper wire there now. So after this we started, we took our orbital and parked it into a proximal LED, next, and tried multiple times, you know.
question for you, Peter.
A question for the panel. As we see more and more programs that don't have backup surgery and are not able to do rotational or orbital atherectomy, to Dawn's point, but we're stuck in a situation where we're supposed to do ad hoc PCI in these people because that's what's expected, because that's what they're told is going to happen if it's possible. How do we communicate that message now that it's okay to stop? Because I think we've got Cardio Solutions, Vital Solutions here. That's their entire program, is in hospitals without on-site surgery. So what do we do in those situations where we do try to stop, but we are in our mind want to go?
I mean, I think guidelines definitely will impact a lot, and from societies and at such meetings when we discuss saying that it is okay to stop rather than trying to do ad hoc PCI without cardiac surgery backup. Even though, you know, in Seaport trial, all of that has been proven that it is all right to do in every situation. But
Maybe
not,
we can let Dr. Kapoor work because all the time
Okay, so as I mentioned, you know, we tried getting the orbital down, show the shots, but orbital, you know, nose cone was actually getting stuck at the same point. And then after a big patience, almost for 15-20 minutes, multiple passes, it was getting stuck at this point, but we maintained our patience, and this is all at 80,000 RPM. We kept the burr there, you know, look at this. So it crossed and jumped at one point, and this is almost after 10-12 minutes of burring. So this is the point actually gave way, and now we are coming back and doing the whole length of the vessel with the orbital. It's a retrograde sending we are doing around the ostial because thickness of calcium was even quite severe at that point. See, can you hear the sound? I'm not sure whether this sound is audible. There's a lot of grating sound while we do the orbital.
It's very important to CSI.
Yeah, with orbital, you do not want to increase to a high speed
Yes.
to get through, because that's where you have the most perforations. You need to stay at low and be patient.
Okay, so
So, Peter,
yes.
I think your question is very, I don't do PCI without CT surgery on site, and I do not think that you're supposed to be doing this, but I don't think there is any regulation that precludes or do not preclude to do these type of procedures
Okay, All Star after
in
this.
sites that do not have a surgical backup.
But our guidelines say we shouldn't be doing rotational atherectomy without on-site surgery there, so we don't have rotational atherectomy in all those places. My question is, should we change those guidelines? Because how often is on-site surgery really making a difference for rotational atherectomy? And to me, it doesn't make sense. I see it in ASC because of the no reflow and the possibility you're going to have to keep the patient overnight, but I don't see it in a hospital where you're doing everything else and now you're stuck with this situation where you can't handle it. So to me, it's a guidelines issue that I think we may need to try to readdress as
Introducer.
Okay, so having done this, we are changing a wire back to the workhorse wire, and then hopefully after this we should have a balloon movement much smoother, and that's what we are expecting.
More sophisticated care after the procedure, so it still applies the concept that perhaps we don't supposed to do that. We don't supposed to be doing this, not because of the need for surgery, because likely the need for surgery is very low, but for the need of a higher complexity care of the patient.
So there are regulations from state to state which differ, right? In Pennsylvania, you cannot touch these patients. In West Virginia, you can touch these patients. So we are just across the state line, and so it differs from one place to the place, and I don't think that is just medical societies or guidelines that alone can restrict them, but making sure that if some center wants to do rotational atherectomy without a surgical backup, to have covered stents, to have some sort of mechanical circulatory support device is very important. Let's take a question from you. I know
one comment and then I had the question. Comment is that about this issue about complex cases doing offsite. So in Vegas, we have like 13 hospitals. In our group, we do not do this kind of procedures in hospitals where there is no mechanical circulatory support. We move them, for example, to the university hospital. One question I wanted to ask before Rajneesh took the orbital atherectomy, if you look at the OCT images, it looks like that there is superficial calcification and deep calcification. Will that make your choice in terms of what device you used?
12, 16.
If it is superficial thick calcium atherectomy for deeper calcium followed by following atherectomy is some sort of balloon strategy. Whether you choose an NC balloon or Wolverine at that time, or a shockwave or a OPN balloon is up to you.
Yeah.
16, 18, 20.
But many of these places that your shockwave or IVL or OPN will not cross if you have so much of superficial.
Check.
Another question is the.
So let's go back a little bit to because we are not going to have enough. Can you tell us a little bit what you are doing and what are your plans now?
2.75.
2.75.
Dr. Kapoor, can you hear us?
2.75.
Yeah, we can hear you. Absolutely. I was engrossed in the steps. So we actually, after taking out the orbital wire, are we audible? Hello?
Yeah.
Okay.
You are audible, Rajneesh.
Okay, great. So we have taken the wiper wire out, exchanged it with the All-Star wire, and then you saw the movement of a balloon. It was much smoother. We have dilated the whole segment with 2O balloon, and I'm giving you a shot after that.
Balloon very fast. Did you stay in the open with the balloon more than a second, or we saw you balloon the whole vessel very, very fast?
Yeah. Okay. So I'm going with the 2.5 balloon now and dilate the whole segment again. We need to have a wire down. Okay. Have some nitro. The wire vessel looks quite
These are NC balloons?
Yeah, these are all NC balloons. Okay. So I understand the discussion was rota. So non-crossable, our policy is also rota. But then here we were kind of prepared with orbital, so we thought let's do that. And in the meantime, we were actually preparing rota also. Okay, go up. 6, 8, 10 down. See, this is that point of the tightest point, and it's actually opening up well. This is 2.5. Check. Go up. 6, 8, 10, 12, 14, 16. Down. Again go up.
Are you going to proximally dilate
14,
with a bigger
16.
balloon or only
16,
2.5?
down, down. No, we plan to actually dilate with 2.75 or 3 balloon. Okay, go up again.
Yeah.
Go up again. 16, 18. Down. Come Mario Caudal. The only thing is, I think Goran was clearly pointing that left main to LED, but I don't know. In my mind, I want to take a chance with ostial placement. Okay, go up on. Okay, 16, 18.
Rajneesh, I don't think we should
20,
make that
down.
decision now. Anyway, after lesion preparation, you will repeat OCT and then you can decide.
Yes.
Yeah, right.
Check. Okay, go up here.
I think that's a good point. You need
18,
to do imaging again.
20 down.
And then decide.
Pain
Maybe a
hoga karo.
dissection extending into the left main.
Okay, give me a 3 balloon. Okay, so we'll show you a OCT image just now. One more dilatation. I'm stepping up the balloon size so that we make the vessel bed, prepare the vessel bed well. Okay. Give me 3 and keep the OCT ready after this. Hai na? So this is almost our second, third case of non-crossable with orbital. I mean, as dictum, it's rota, but somehow we got stranded in one more patient like this where it was non-crossable. This is 3O. So we don't require.
I agree with you.
Check.
I don't think that we can say that uncrossable lesion, that orbital does not work. That's not a true statement. We have to be very careful in that.
6.
Because as you did,
10,
if that was a rota 1.25,
down.
you would have jumped in and got stuck. Whereas here you can come back with the ablation again backwards as well.
10, 12. There are other advantages. There is no slow flow with orbital, I mean very less. And then TPI is not required. So slow flow with the rota is much more. If I think we would have kept the burr in LED for so long with the rota, definitely we would have a much bigger slow flow. Go up again. 6, 8, 10, 12, 14, 16 down. So this is dilatation with a 3O balloon. We have done it aggressively, and I'm showing you one more OCT image now. I think only way with orbital, thinking with a non-crossable lesion, you have to be very patient. I mean, keep moving the nose cone of orbital, very slowly, gradually towards that non-crossable point. It is modifying the calcium in the vicinity very slowly. We can't be very fast as we do with the rota burr. So this mechanism is different. So we have to be very diligent and very patient while using this orbital. Okay, go AP cranial, please. AP cranial. This is now the OCT. Look, the passage is very smooth, and this has crossed the tightest point.
But we have 30 more minutes for the session.
Okay. Okay, ready?
It's 10:45.
We are ready, chalo.
10:30. Oh, okay, there you go.
Yeah, here it says 10:45.
Ten 30, yeah.
हाँ हाँ हो जाएगा, ठीक हो जाएगा। इनको ट्राइमोडोल लगवा दो इनको। ओके लेट्स स्टार्ट स्टेंटिंग। हाँ 2.5, हाँ हाँ हो जाएगा, आराम से जाएगा। 2.5 into 33. Continue to give IV saline. There's some diagonal slow flow. Is it a good image?
Can we have it in a larger because it's very small?
Vessel is small, yes. हाँ ठीक है, जितना है वो दिखाओ. Yeah.
Okay.
Okay, so this is the vessel. I think it is vasoconstricted. So let's give some nitro also, and then let's start taking stents. So 2.5, 33 Zymes. Do we have some osteal image also? This is where? Huh? So there is lot of blood there, right?
There's a dissection there.
Yeah, there's a dissection here, but this is in LED. So this is beyond ostium. We are into the LED. So obviously we have done orbital, very aggressive dilatations, but there is calcium modification definitely which has happened. There are cracks visible. Show some cracks here.
Yeah, definitely a lot of cracks.
You look at this. Look at the 12 o'clock position and the 6 o'clock position, and move ahead. Come distal. Yeah, look, yeah. So these are the cracks. I think we have modified the calcium in the vessel, and for the sake of it, I'm going to put one stent down. There are some slow flows happening. Okay, give 33 lines or 38. Okay. So fast.
So, Rajneesh, if it's okay with you, I think now you're planning to put 2 stents.
Yeah.
Okay. If it's okay with you, we'll go to Dr. Chandra's room and come back to you at the end, okay?
Absolutely fine.
Okay. Thank you very much. I think probably some people would still, as Dr. Hassan was saying, would still do a shock wave because there's some deep calcium there. I don't think that there's anything wrong with.
Okay, Jao. 6, 7, 8, 10, 12. Down.
2.58 दे दो.
I think this was a beautiful demonstration of being patient and doing the atherectomy completely and then modifying. So you really showed that.
Yeah.
6, 8, 10, 12. 14 down.
फ्लोरो करना 1 मिनट.
शुरू करा दो. हाँ अभी ठीक हो जाएगा.
ये कर दो, रीसेट कर दो फटाफट. तब तक
जाओ.
पिछले प्ले कर दो.
10, 12, 16 down.
We're back with you, Rajneesh.
Yeah, so I'm just at a crucial step of catching the ostium of the LED, and I'll tell you what we have done. Okay.
And we have the images of the angio.
Check.
Can you please show us the angio screen?
Please show the angio. Yeah, screen live. Screen live. Okay, yeah.
We can see it.
Yeah. Iliocordal, please. So what we have done, there was a tight lesion at the high obtuse marginal. So while we have now prepared the bed of LED, we have done a drug-eluting balloon out to the obtuse marginal ostium, and now back with the stenting of this LED.
Okay.
Yeah, this looks okay.
And from what I'm seeing, your intention is to put a stent right at the ostium, not to cross over, correct?
Absolutely. We have done one more OCT, which I'm showing you in a second. Okay.
Okay. Yeah. You go ahead and we'll watch and
Check.
So, and then we'll make final comments after you repeat another OCT. But, obviously we have done our own studies where looked at precise placement of stent versus crossover. Obviously,
Okay, go up.
crossover is recommended, at least in our study.
10, 12, down. हाँ अभी ठीक हो जाएगा. Down, 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 down fast. Come epicranial. Have we taken that? नहीं वो तो कोई बात नहीं. Take shot. Okay. Yeah. So yes. So now we have done that, and I'll show you. OCT we again took because ostium of the LED was not clear in the previous OCT image. So please show the OCT again. Just focusing on the LED ostium and the left main. So this is that ostium. This is that OCT image. Can you make it bigger on the screen? Yeah.
We don't know if you did something offline. So what we are seeing is the OCT post-stenting and post-dilatation, or just post-stenting?
No. This is OCT prior to this stent at the LED ostium. We wanted to be sure whether left main distal is sound and healthy. So show the left main. This is left main distal, and it looked good to us. There is no big atheroma there. I mean some plaquing. That's it. And come towards the LED ostium now. So we are entering the LED ostium. Look at this, and that's where we decided let's keep the stent right at the ostium. And now having done this stent, I am giving you another picture with the OCT with after the stenting now. Although we need to post dilate little bit, but I think for the sake of time, I'll show you a OCT image prior.
Sure.
Yeah, this is.
We have 10 minutes anymore anyway, so I think I'm sure you'll be able to complete that.
So, Dr. Praveen, it seems like you do like only less than 10 second, maybe even 5-second inflations on the balloon with the stent. Is that how you do it?
They're all pressed with the time. Actually, obviously Medanta is one of the largest volume center in India for both coronary and structural. But when we give them half an hour and ask them to do a complex PCI, which we take about 1 hour in our center, that's not fair either. So I think both Rajneesh and Dr. Praveen Chandra, both of them are key opinion leaders. They know obviously all the steps of PCI. On the screen, you might see that 5-second inflations, please. That doesn't mean that they are not following up with the optimization with the NC balloon and repeat imaging, and if need be, longer inflations as well. For the audience, just want to make sure that don't take home that I can do 5-second inflations.
So the message is not short inflations. This is for the sake of time in the live case, but we do wait for a second for few 10 seconds or so with any inflation. Okay. So this is a OCT image. Is it? Oh, they are formatting it. Okay. So this is after stenting. So look at this. Right at the ostium. This is our stent. Come back from left.
Can you make OCT bigger?
Yeah, please make it bigger, full screen. Okay. Yeah. No, come again from the left main. So yeah, so this is left main. There is circumflex ostium. Come back. Come into the LED. So we are entering into the LED, and here is the stent. Okay. Move. So this is all the stented segment in LED now. The area is 6.9. Although we need to post dilate aggressively still. We are going to dilate with
Dr. Kapoor, can we go to 3D bifurcation mode?
3D bifurcation mode.
3D bifurcation.
Yeah, we are showing to you, Goran. Yeah, look at this.
This is definitely precise placement, right, Goran? What do you think?
This is super precise.
Okay.
I thought he would be back at least one stent strut into the left main, but actually he proved me wrong. So.
Dr. Kapoor, congratulations. This is really masterpiece of work.
Thank you. Give me a post-dilating balloon, NC, first 3 and then 3.25. So this is in the vessel, and it looks well opposed. There are no red signals, but still our job is we are going to do aggressive post-dilatation. And in the meantime, also as I was mentioning, we thought of doing a drug-eluting balloon to that high obtuse marginal. Okay, can you show that image also?
Yeah, excellent.
Was there any calcium in the osteal OM1?
No, no, there was no calcium.
No.
And we had it's a softer vessel. First we dilated with 2.5 normal balloon, NC balloon, and then took again 2.5 DEB, drug-eluting balloon. Protege was the drug-eluting balloon, which has a paclitaxel. And we dilated, although we were finding little difficult because it's a dominant circumflex to continue for the 1 minute time. But yes, we did 30 seconds and 30 seconds again immediately. And that's how we completed that DEB. And how it looks like, I'll show you. Take a shot. Come, Arya Caudal, please.
So the advantage of that drug-eluting balloon is that you can do multiple inflations rather than just one inflation.
Yeah, there's a protege.
Yeah, protege, right, which we do not have in the United States.
Yeah, we do have it. So you do it at different pressure inflations, and those wrap around doesn't open that at low pressure and high pressure. 3 times you can do it.
Yeah. You essentially can use it for 2 lesions.
Yeah, you can use it, but you can inflate 3 times.
3 times, yeah.
Yeah. Okay. So we can have that image of this vessel also, but we deliberately didn't use a cutting balloon. In such settings, we first use a cutting balloon and then do the DEB. But here it is too close to the circumflex ostium, and we need to actually protrude into the circumflex to do the cutting. So I was not ready or comfortable giving a trauma to the circ ostium. Is a very big vessel. Okay, come apicranial. So now we are on to the, I'm taking over, where it's intertwined. Okay, check. Okay, go up here. 6, 8, 10, 12, 14, 16.
So Ramesh.
18 down.
Ramesh, that balloon was from which company? The drug-eluting balloon we just spoke of.
18.
Yeah.
So Don,
okay.
making some comments, Don?
No, I was just asking which company is that balloon from that you were just speaking of?
Protege?
Uh-huh.
I also don't know. Rajneesh, what company makes Protege?
So Protege actually is being marketed by Translumina here. They have stents, and it's practically with the collaboration of some German company. They have made this DEB, and we are doing a study on that DEB also here. Okay, show me that.
So Translumina is a company that distributes in India and Pakistan.
Okay.
Yeah.
Go up. 6, 8, 10.
We can get from
16. 18, 20 down.
Barbados.
I think in India, at least there are, in Pakistan as well, Bashir, you know, so probably about 15 drug-eluting balloons.
Yeah, they're different. There are multiple companies, and we actually, because we have a lot of diffuse disease and we use it quite commonly.
Yeah. So right now we have only 1 approved from Boston and 2 are in clinical trials. 1 is from India, the Magic Touch balloon in our center. And then the other one is Cordis, which is solution for small vessel disease.
Down. Okay, 2.75.
Any other comments from our panelists? And then I think we have to close.
Okay. I think these were both great cases. I think they help us think about complex calcified lesions from the standpoint of taking time out to really think about your strategy and have a planned progression of how you're going to move, and also the importance of imaging to help you define the complexity of the lesion. Even though it may appear to be slightly calcified, it may be more calcified than you appear, or if it's heavily calcified, again, just to help you get with your strategies.
Yeah, I think great cases, both of them. Really, the key message is the planning and the preparation. That's the most important. One thing I would like to say that we do it, and especially when we are not planning to use the support device, that we always check the LVEDP, and that gives us a good information and prepare the patient accordingly beforehand.
Absolutely.
Always.
Go on.
I can just congratulate to both Dr. Chandra and Kapoor. Excellent demonstration of how to apply modern technologies to prepare calcified lesions and perform stenting.
So
Congratulations to both.
this is the last shot. Look at this. So where we started and how the vessel looks like. And although I think we are not having enough time, so this is the last angiographic shot. Still some post-dilatation required at the tightest point around diagonal. I've done post-dilatation with 3O balloon with 20-22 atmospheres in the proximal LAD. So we are changing a balloon to 2.75 and doing a post-dilatation down. But I think this is with orbital, with calcium modification, this looks like good.
So Rajneesh, that diagonal is lost, but it is small. Are you trying to go back up there?
Yeah.
Okay.
There is a faint flow
Louis,
coming.
any comments?
No, I just want to re-emphasize the importance and also how we saw in all these cases in this morning, because the previous session was also calcified lesions, how intravascular imaging is so important in trying to plan the procedure and how adjusting the procedures accordingly, because we have done a lot of adjustments according to intravascular imaging, not only in left main bifurcation, which was the first case this morning, but also in mid-LADs and long lesions. So congratulations to both Dr. Chandra and Dr. Kapoor for the great cases and great demonstration.
Thank you.
Yeah, thank you, Rajneesh and Chandra. I would give the opportunity to Dr. Manish Parikh, who is the coronary track director, program director, to close this session. Thank you.
Yeah, no, so fantastic sessions. Again, very valuable. The way they were done, challenging cases, no one right way of doing it, but clearly plaque modification and imaging is here to stay. In the United States, we're only doing 28% imaging still, despite all the data. We're way behind the rest of the world, and hopefully with meetings like this, we're going to improve our image-based PCI moving forward. So really looking forward to that. So Dr. Kapoor, congratulations. Thanks, everyone.
Thank you.